Hi, this is Professor O'Connor, and this is part 5 of your pre-class assignment, and it's talking about bronchiolitis. The etiology of bronchiolitis is there is an increased incidence of reactive airway disease and asthma later in life for babies who've had bronchiolitis, and it generally occurs from October through March or April. Pathophysiologically, the respiratory syncytial virus is the most common cause of our bronchiolitis. Direct contact with the secretions or indirect contact with contaminated surfaces is the vector, and the virus is shed for 3 to 8 days, the incubation period of 2 to 8 days, and the cell debris clogs the bronchioles. Diagnostic procedures. First obtain a history and physical exam. They may also do chest x-rays, which will show patchy atelectasis. And the last thing is either a nasal wash or a swab for the ELISA test, and that is the definitive diagnostic procedure. There are 2 YouTube clips here. One is one that was just in the last screencast on bronchiolitis and croup and what are the differences, because one is lower airway and one is upper airway. And the other is on wheezing and bronchiolitis, so that you can hear the wheezing and see the baby from that perspective. Signs and symptoms in your assessment findings. The child will have rhinitis, clear, copious drainage from their nose. They will have a cough, a low-grade fever. They will have expiratory wheezing, retractions, nasal flaring, and grunting. They will have poor feeding because they can't coordinate feeding because they haven't got the nasal breathing down. And they will have vomiting and diarrhea, and they will become dehydrated. They will be increasingly irritable, and they can have severe dyspnea with a respiratory rate greater than 70 breaths per minute. Medical treatment and prophylaxis. These children need to be on isolation. You can room 2 of them together, but they have to be on isolation. Droplet precautions. They need humidified oxygen to keep their O2 sats greater than 90%. They need hydration, IV and then PO. Nasal suctioning needs to be done. Chest PT is ineffective and so does not need to be done. These children will receive hypertonic saline nebs. Albuterol nebs are basically ineffective. They don't really work, and it just makes their heart rate well up over 200. CPAP for moderate to severe cases, and prophylaxis can be done with intramuscular injections of palivizumab or Synagis immunizations, which I'll get into at the end of this little screencast. There's a bronchiolitis score, which is a great way to score how severely ill the child is. And you would score 0, 1, 2, or 3 based on what their respiratory rate is, what the retractions are, is there nasal flaring present and how severe and continuous it is there wheezing and can it be heard with stethoscope or heard without a stethoscope, and general status. Are they normal, moderately uneasy, very uneasy with a continuous cry, or lethargic? This is very handy to use. So it would give them a score of 15 as a max. For your nursing assessment, you need to get a past medical history. There may be a history of chronic lung disease, such as bronchopulmonary dysplasia from prematurity. They may have complicated congenital heart disease or an immunocompromised status. We also want to get a birth history. Was the baby premature? Were there multiple births? Was the birth during April to September? And is it a male gender? We want to get a current medical history. How old is the child? These children tend to be under 2 years of age. The more severe the illness in the baby would be in a baby under 6 months of age. Exposure to passive smoke, secondhand tobacco smoke, crowded living conditions. Does the child attend daycare? Are there school-age siblings? What's their socioeconomic status? They tend to have a lower socioeconomic status. And is there breastfeeding or not? These children tend to have a lack of breastfeeding. Then we're going to look at chief complaint and signs and symptoms. So the chief complaint and signs and symptoms, the biggest thing is that clear, copious nasal drainage at the onset of the illness. They will also have pharyngitis, a low-grade fever. They will develop a cough 1 to 3 days into the illness. And that's because they just can't handle those copious secretions. They develop wheezing shortly after that and poor feeding because they can't coordinate breathing and feeding. For under physical exam, inspection, and observation, we want to look at their general appearance and color, both centrally and peripherally. They might show the signs of air hunger. They will have various degrees of cyanosis and respiratory distress. They will be tachypnic. They will have retractions. They will be using accessory muscles. You may hear grunting. They may have periods of apnea. They will definitely have a cough. And if it's a severe case, you will be able to hear an audible wheeze on expiration without a stethoscope. If it's moderate, with a stethoscope. And they may appear listless, uninterested in feedings, surroundings, or their parents. For auscultation, note adventitious breath sounds. Determine the quality of the lung fields. If it's early in the illness, you may hear wheezes scattered throughout. In a more serious case, the chest may actually sound quiet and without any wheezing, and that's because of significant hyperexpansion and poor air exchange. For the lab and diagnostic tests, pulse oximetry might actually show that it's significantly decreased. A chest x-ray might reveal hyperinflation and patchy atelectasis or infiltration in the lungs. Blood gases might show CO2 retention and hypoxemia. And the nasopharyngeal washings or swab can identify RSV via the ELISA, enzyme-linked immunosorbent assay, or IFA, immunofluorescent antibody. For nursing management, one of our goals is to maintain a patent airway, so we want to elevate the head of the bed to facilitate the airway remaining open. We want frequent assessment and suctioning. Use a Yankauer or tonsil tip suction in older infants, and use a nasal bulb suction in younger infants. We want to promote adequate gas exchange, so we want to monitor the work of breathing, the respiratory rate, and the oxygen saturation. We're going to adjust the FiO2 or the oxygen level to maintain oxygen saturation above 93% and elevate the head of the bed. We want to reduce the risk for infection, so institute and maintain droplet precautions. We can put 2 infants with RSV together in the same room, and hand washing is imperative. We want to provide family education. We want to teach the family how to recognize signs of a worsening condition and when to call the healthcare practitioner, and that would be if breathing is more rapid or more difficult, if the child cannot feed or eat because of the tachypnea, if they are under 1 year, they are at higher risk, and if the cough persists for several days to weeks after resolution of the disease, but act well otherwise. And I want to say that RSV is not something that only infants get. Older children and adults get it, and it is just a very severe head cold with clear, copious secretions, and that's how the infant gets it, is usually the older children bring it home to them. To prevent the disease is actually going to be discussed on the next slide. So palivizumab, or palivizumab, is the monoclonal antibody given as a monthly IM injection to at-risk children who are 2 years of age or under and were born prematurely, have chronic lung disease like bronchopulmonary dysplasia that requires medication or oxygen, that have a certain congenital heart diseases, or are in an immunocompromised state. Ribavirin is a medication used to treat RSV. If the infant or toddler is ventilated, then ribavirin can be administered. It's an antiviral that's specific to RSV. It's administered as an aerosol with a small particle generator, or SPAG. That's really important information to know. And if the child is ventilated, they need to be suctioned every 2 hours. Pulmonary pressures need to be monitored every 2 to 4 hours, and the medication itself can cause blurred vision and photosensitivity. And another key fact to know is that pregnant women should not be exposed to this drug as it has teratogenic effects. This is the end of part 5. Thank you for your attention, and please go on to part 6, which is the last of the screencasts.